Hello again, Dr. Mashburn, and so today we're going to talk about disorders, bleeding and clotting disorders. So we've learned about the different types of blood cells. We've talked about how blood clots. We've talked about blood typing. And so hopefully we're going to talk about now what happens if you have a bad reaction or something's going wrong and causing your blood to bleed maybe uncontrollably or to clot in a unnatural or abnormal way. So there's several disorders of hemostasis. Remember, hemostasis is how we stop bleeding. And you have what are called thrombolytic disorders, and they're just straight bleeding disorders, and then what's called DIC, or disseminated intravascular coagulation. So a thrombolytic disorder is an undesirable clot formation. So you're getting a clot where you don't want it to. We're going to talk about some times when that would happen. Bleeding disorders are things that don't allow you to form a normal clot. So maybe you're a free bleeder. We'll talk about some things like that. And then DIC, this is when kind of both of these things are going on at the same time. So normally you don't have clotting in your vessels. I mean, your goal is to prevent that. Okay, so you prevent your platelets from adhering by keeping the endothelium smooth, and as long as it's intact, the platelets are going to just glide through the vessels, so you're not going to get that fibrin mesh, you're not going to get a clot, you're not going to get this happen. Because we have things like nitric oxide and prostacyclin that the endothelial cells secrete that don't allow platelets to adhere. They'll just smoothly go through. So remember, when you have a cut and the endothelial lining is exposed, then those platelets get sticky and they start to attach and form that clot. Vitamin E also acts as an anticoagulant, so it prevents things from coagulating in your vessels. But sometimes things do happen. So a thrombus is a clot that develops and stays in an unbroken blood vessel. So this is something that could block circulation and lead to death. So maybe a blockage of clot that has formed in a blood vessel and perhaps could cause a stroke or something like that. So it's a clot that develops in an unbroken blood vessel. Okay, an embolus is when that clot breaks free and is freely floating, but it can get stuck somewhere. Okay, that's the danger of an embolus. So a thrombus, when it breaks loose, can become an embolus. And so if you could have an embolus like a pulmonary embolism, this is where a clot has broken free and now has blocked one of the vessels in the lungs, which is going to prevent blood flow, which is going to prevent gas exchange. You can also get them in the small vessels of your brain. It's called a cerebral emboli. And again, that could cause like stroke-like symptoms, lack of oxygen exchange in your brain, and possibly stroke or death. One of the things that can lead to thrombi being formed is something called atherosclerosis. And so you have like plaque buildup in the vessels, and so the plaque is there. So if you have a vessel and now it's not smooth anymore, it's got these plaques, and so now that it's not smooth, those platelets, they have something to catch on, and then you start to form these clots. And so this is what happens sometimes when you get like a heart attack or stroke. Atherosclerosis, you have this non-smooth endothelial layer which allows the formation of a thrombus inside the vessel. So either the thrombus itself can block off and cause ischemia and hypooxygenation to an area, or that thrombus can break free, become an embolus, and then travel somewhere and cause damage that way by clogging a vessel. So a thrombus and an embolus are just clots inside of a vessel. Now, if you're prone to strokes and heart attacks and things like that, they may give you an anticoagulant to prevent those thrombus from developing, and so therefore prevent it from breaking free and becoming an embolus. And so aspirin is one of those things. It's an antiprostaglandin. It inhibits, I'm having trouble talking today, inhibits something called thromboxane A. And so again, it's going to prevent those platelets from sticking and clotting. Heparin is something that you'll give people. It's also an anticoagulant. You give it a lot of times to people that are having cardiac care, post-cardiac care, so to help prevent heart attack. Warfarin and Coumadin are also forms of anticoagulants that you'll see. It works by preventing it interferes with the action of vitamin K. Remember, vitamin K is helps with manufacturing clotting factors. You may see this in someone that's got atrial fibrillation, and we don't really know what that is yet, but it's where the small chambers of your heart, they're kind of at the top, they're not beating correctly. They're kind of shaking, and they're not effective. And so because they're not pumping like they should, sometimes blood can kind of get held up and kind of clot in the heart. So you might want to give warfarin for that. And this is another one, dabigatran, that's also used sometimes for an anticoagulant, and it inhibits thrombin. So if you don't remember what these are, go back and remember we had the prothrombin and thrombin and fibrinogen and fibrin. So kind of go back and see how all of these relate to blood clotting and hemostasis, and where you could interfere with that pathway to prevent the blood from coagulating and clotting. Some other bleeding disorders, thrombocytopenia. This means, so thrombocytopenia means you don't have enough platelets. That's a long term for just saying there's not enough platelets. And so if you don't have enough platelets, you may get easy bruising, but one thing you see is what are called petechiae. And so they're like little red, almost like red bruises, like bright red bruises instead of dark red bruises, if that makes sense. And so it's really due to hemorrhage. Okay, so that normally when platelets would start that coagulation and stop the bleeding, and this not working, so you're kind of getting this bright red looking hemorrhage, and so you may see it in the eyes, and you can see it, all over the skin depending on where it is. It may be due to, for some reason, you don't have enough platelets. One of those reasons could be maybe cancer, or maybe you're being treated for cancer. So something that's destroying the red bone marrow, because remember that's where your thrombocytes are made. So you want to have over 50,000 platelets per microliter. So if it's below that, that's diagnostic that maybe something's going on and you need to get that checked out. You can treat that with a transfusion of platelets and get your platelet count back up, and hopefully these symptoms will resolve. But you got to figure out what's causing that thrombocytopenia in the first place. Some other bleeding disorders have to do with the liver not working right. And so remember, the liver is going to function to make a lot of those procoagulants. Remember all those factors that we talked about that you use for clotting blood. So if you have liver damage, like hepatitis, which is inflammation of the liver, or cirrhosis, which is sometimes associated with alcoholism and liver damage, or vitamin K deficiency, any of those things can cause the liver to not work right, and it can't make those procoagulants, and so then therefore you're not going to have the factors that you need. Remember, vitamin K is needed for 4 of those clotting factors to be formed. So liver damage can cause you to have bleeding disorders. Hemophilia is a kind of a common one that people have heard of. It's hereditary, and we call those free bleeders. So you may have heard of someone being a free bleeder with hemophilia. And so there's different types of hemophilia, A, B, C, and each one of them is missing a certain of those clotting factors. Okay, so the most common one is hemophilia A. About 77% of hemophiliacs have this form, and they're missing factor 8. But there's also hemophilia B, which is missing factor 9, and then C, factor 11. So again, they're just missing genetically. Remember, DNA codes for proteins. You need these proteins, so somewhere in their genetic makeup they're missing the gene for making these particular factors, and because they're missing that factor, remember that cascade, somewhere along the cascade you've got a hiccup, and so therefore your clotting's not going to occur. So people with hemophilia, if they cut themselves, they're going to bleed a lot. They may have a lot of bruising, because you're bumping into things all the time and breaking small vessels. Well, normally where we would bruise, they're just going to continue to bleed and form a big old hematoma. They can bleed into joint cavities. They can bleed into their abdominal cavities. So these people have to have transfusions, and they give them the missing factors. So they take blood donors. They isolate out the factors that they're missing, and they give those to them in transfusions. Historically, one of the problems with hemophilias is they're users of blood products, and so before we knew that some diseases were carried in blood, like hepatitis and HIV or AIDS. So some of these patients wound up with hepatitis and HIV because the donors that gave the blood had that in their blood. We didn't realize at the time that it was a blood-borne illness, and so then you transfuse these hemophiliacs with the blood, and they wound up with a whole other disease. We do have more routine testing of our blood, and so that happens less and less commonly now, but that is a risk factor of a blood transfusion, is you can get a disease that's being carried in the blood like HIV. One kind of cool thing about hemophilia, and you can maybe go online and look this up, is a lot of times it's inherited from the mother. Hemophilia, the gene, you get one gene from your mom, one from your dad, and sometimes this hemophilia gene is on the X chromosome. It's on the mother's genes, and so you get that from your mother. She may not have hemophilia, but you get it from her. So that's just kind of a cool sideline. You may want to go read about that, and go read about the Russian family. There's a famous Russian family. They were in power before the Russian Revolution, and so you might want to go look up about them and find out which one of them had hemophilia. Just for fun. All right. So the other one is DIC, disseminated intravascular coagulation, which we call DIC because that's easier to say. And this is when clotting causes bleeding. So if you go back to that slide, I said this is when all things go wrong. So you've got this widespread clotting that's blocking these blood vessels. And what happens is you have a lot of bleeding, and so you've kind of used up all your factors. So something's causing bleeding, and you've tried to clot it, but you've used up your factors, and you continue to bleed, and so you get this widespread bruising. Sometimes it's a complication in pregnancy. Sometimes it can be due to septicemia, which is like a blood infection. It can be due to an incompatible blood transfusion. So if you haven't done your blood types yet, we talked about you have A and O and B blood, and so everybody can't have everybody's blood. You have to be able to know who can give to who and who can take from who. And so that's why typing blood is so important. So if you were to give A blood to an O person, you'd have a transfusion reaction, and you might get something that looks kind of like this. Sometimes you'll see it at the very end of life when organ systems just start to fail. You may start to see this DIC as kind of a last sign of life in kind of end organ failure patients. So going back to blood types, we talked about you have A and O and B and AB, but we also said that that's either positive or negative. So if you haven't watched that video yet, you'll need to go back and watch that. So you can have A positive blood, A negative blood, O positive, O negative, and so on and so forth. And so if you remember when we talked about that when you have A blood, remember you have A blood, you have those B antibodies, right? Those anti-B antibodies. And so if you are Rh positive, you don't really have any antibodies because if you don't want a positive antibody because you don't want anything that would attack that because you are Rh positive. If you're Rh negative, you don't have the Rh antibodies initially. You have to be exposed to those. You have to be exposed to Rh in order for those antibodies to be formed. So something called hemolytic disease of the newborn, or erythroblastosis fetalis, it occurs when an Rh negative mother has an Rh positive fetus. Okay, so that means mom is Rh negative and dad is going to be Rh positive. So remember, so you got the two alleles come together. Now the baby is going to be Rh positive. All right. So during pregnancy, so here's Rh negative mom and here's Rh positive dad. And so positive is dominant. So if you remember your alleles, like big B, little b, now the baby is Rh positive. And so there is some, there's not a lot of mixing of fraternal and fetal blood, but, little things can break, vessels can break, and somehow, just during normal pregnancy, some of those positive RHs can get out into the body, okay? And so now mom has been exposed to that Rh antigen, and she's going to start to react to it, and she's going to start to mount an antibody. She's going to start to form antibodies to that Rh. That's what these are, okay? Well, That's not too big of a deal because usually by the time this happens, it takes a while for her to mount that immune response, and that baby's carried to term and everything's fine. But the second time she gets pregnant, okay, so now they've had, baby number one has come and gone, and now we have baby number two in utero. And so as she's being exposed to these positive antibodies, or these positive antigens, she really has a huge reaction. So lots and lots of antibodies are going to be produced, and it's going to attack the fetus. And so the second child has a increased risk of the baby being destroyed as a foreign object in the mother's body. Because again, those antibodies cross the placenta, and so every time subsequently that she's exposed to Rh positive, she's going to mount a bigger and bigger response. And so we're going to talk a little bit about how that works when we talk about the immune system. So what they do is they give something called RhoGAM, and that's gamma globulin. So it's a serum that contains anti-Rh antibodies. Okay, so they're the anti-Rh antibodies. And so you give that, and they go in and they kind of gobble up all those positives. So remember those antibodies, and they're looking for that shape that's kind of the mirror image to grab up. So if you give her Rh positive antibodies, they're going to kind of go in and grab up all of those Rh positive fetal cells that are marked with that antigen and kind of agglutinate them and get them out of her system and get rid of them. And so that prevents her own body from mounting that immune response. And so once a mother is Rh negative and she's had a Rh positive baby, they're going to give you RhoGAM so that she won't attack the fetus. Now, if you're Rh negative, don't be surprised, even if it's your first pregnancy, that they give you RhoGAM, because a lot of women are pregnant and never know it. You may spontaneously miscarry within the first couple of weeks of pregnancy, and you never knew that you were pregnant, so never knew that you'd already been exposed to Rh positive antigens. So a lot of times they'll just go ahead and give a Rh negative woman RhoGAM just to be on the safe side, because like I said, you may have been pregnant and did not know it. Again, there's some more information in your book and online, but it's an interesting thing for women to know and understand. Know your blood type. So if you don't know your blood type, you can go give blood at the American Red Cross, and they'll type it for you. But you should know if you're positive or negative, because that's a big deal going forward with pregnancy. Okay, so we all know that someone's been injured, and so they're bleeding out, and so they need to have a blood transfusion, or maybe they've been in an accident, or maybe they're saving blood. They're going to have a big surgery, so you're going to wholesale save your blood so that later on you can use it after surgery. Well, since sometimes when there's an emergency, you've got to get somebody else's blood, which is why it's important to know your blood type. So if you haven't done the blood type videos and figured out how to cross match donors and recipients, you need to do that. But when they do blood transfusions, there's really two ways they can do that. They can give a whole blood transfusion, and so this is going to be when you're having a really fast, large loss of blood. They want to get your volume and red cells and everything back up. They'll give you whole blood. But a lot of times they can just give you packed red cells. So this isn't necessarily when someone's lost a lot of volume, but they maybe need some more oxygen carrying capacity. Maybe they're a little cyanotic or hypoxic, so they can give you more red blood cells to kind of ramp up your ability to carry oxygen. Sometimes athletes do that. So instead of giving EPO, that erythropoietin we've talked about, they'll just infuse red blood cells into their body to increase their oxygen carrying capacity. But either way, you've got to make sure that you're giving the right blood to the right person. Okay, you've got to know the blood type, because if you don't, if you give an incompatible transfusion, that can be fatal. All right, so we want a blood type. So again, if you haven't watched that video, make sure you learn about blood typing. So you want to make sure that you're not mixing antibodies, okay? Because if you're mixing A, B, and O antibodies in the wrong type, you're going to get that agglutination, okay, and you're going to get that clumping, and that can cause clotting and then severe problems and blockage of arteries and things like that. So when they blood type, they're blood typing for ABO and RH. And actually, there's about 30 other factors. So depending on what you're going in for, and maybe if you're immunosuppressed or something like that, they may even match you out to even more factors than just those ABO and RH factors. So what they'll do when they're matching you, they'll take your serum and the donor's RBs, and they'll mix them up just like we did in our blood lab, and they're going to look for that agglutination. Okay, so that's what they're doing. So just like what we showed you how to do in lab, where you have your little tray, and you put your plasma, your serum in the tray, and then you add your blood, and you watch for the clumping. That's what they're doing. All right. So if everything's fine and there's a match, you don't have to worry about it. But if somehow something's missed and you get a mismatched blood, then the donor cells are going to be attacked by the recipient's plasma. Okay, it's going to start to agglutinate, and it's going to start to clog these small vessels, and that can cause a rupture. That can cause the release of hemoglobin into the bloodstream, which can be toxic. It can cause you to have low oxygen carrying capacity. It can cause damages to be blocked and have hypoxia downstream. Think about like a stroke or a heart attack. It can cause renal failure because hemoglobin is toxic to the kidneys. And we call that a acute hemolytic reaction. So here's just a whole list of things that can happen if you have a bad blood transfusion. So in an emergency situation, if you're in a trauma situation, I'm just going to ask you this. I'm not going to tell you the answer. So if you were to be in an emergency situation and they rushed you to the hospital and you only had seconds, before you were, you're a goner, and they've got to give you blood and they don't have time to type you, and there's just no time, they're just going to start pumping that blood into you, what type would it be? Who is the universal donor? Okay? And on the flip side, these are test questions. So I'm going to tell you the answer. You got to figure it out. Figure out which blood type would be nice to have so that you would never have to worry about who your donor was. So if you had this particular blood type, you're the universal recipient, who would you be? What would your blood type be? So that's on you. You figure out who the universal donor and the universal recipients are. Okay, I may have already shown you somewhere in a slide. Maybe not. We'll just have to see if you can figure it out. But that would be a great test question. All right. And sometimes it's you have to restore blood volume, and that's why it's important to get that blood into you quickly, because if you're bleeding out with large volumes, you're going to lose your blood pressure. So volume is what's keeping your blood vessels full and keeping your blood pressure up. And so if you lose a lot of blood volume, you may have shock. And so if you're in an emergency situation and you're going into what's called hypovolemia or hypovolemic shock, they may not worry too much immediately about agglutinins and antigens and A and O and RH. They may just want to get your blood pressure back up. Let's keep you alive, then we'll figure out what your blood type is. And so what they can do is just give you basically normal saline and just give you an IV of fluids and just push that pressure back up, get the volume back into your system, keep your blood pressure up, keep your heart rate up, keep your cardiac output up, and just keep you alive. Then we'll figure out if we need to give you some red blood cells and whole blood cells or whole blood and all that. So to keep you from dying from shock, they may just give you saline, or there's some other what are called plasma expanders, and they're just they're isoosmotic so that they don't cause your red cells to shrink and expand, and we talked about that in Anatomy 1. One little side note, back in World War II, that's a long time ago, in the South Pacific, they found that they could use coconut milk or coconut water, so the liquidy stuff inside of coconuts, as to prevent shock. Now, it doesn't help you with carrying oxygen. There's no cells in it, but if you were becoming shocky, they could at least get that coconut water in you, because it was very isotonic to blood plasma, and they could do that as a quick plasma expander and get your blood volume back up, prevent you from going into shock, stabilize you till they could get you somewhere for more help. So again, just a freebie, just interesting. All right, that's it. So I will see you in the next video. Thanks again.